Hello everyone. Welcome back to our IBD series. So this is Pouchitis part 2, diagnosis and management for surgical residents, and this is the fourth topic we are covering in the IBD series. I hope you have already watched the first part of this video, that is Pouchitis part 1. If not, do watch it now to have a better perspective, and the first part is available as a free video on our app and on our YouTube channel. So do watch it now. As I said in the first part, that these are uncommon patients or uncommon scenarios, but as a surgery resident or a GI surgery aspirant, we should be well aware of this entity, how to diagnose and how to treat. The background and introduction, anatomy of pouch, pathogenesis of pouchitis, risk factors and presentation, the role of pouch endoscopy, and pouch disease activity index we have already covered in the part 1. In this part, we will touch upon the treatment of acute pouchitis, the different type of pouchitis classification, relapsing pouchitis, antibiotic dependent pouchitis, chronic pouchitis, relevant literature review, the secondary pouchitis, and the Cochrane review. So before we dive into the topic, so here's a question for all of you about pouchitis, that we have a 30-year-old man with a history of ulcerative colitis and stapled ileal pouch anal anastomosis is seen in clinic for follow-up. Over the last 10 days, he developed increasing rectal urgency, tenesmus and diarrhea. 4 months ago, he had similar symptoms and was diagnosed with acute pouchitis. He was treated with ciprofloxacin and his symptoms resolved with treatment. So now again patient is symptomatic after 4 months with one course of antibiotic. Which of the following is the most appropriate therapy at this time? That can be metronidazole 500 mg BD, ciprofloxacin 500 mg twice daily, BSL-3, that's a probiotic, mesalamine enemas, or a prednisolone 40 mg daily. So just I try to think, and then we will discuss the answer with relevant explanation at the end of this video. So basically we have three classification system for acute pouchitis. So depending on the duration or episode and number, or response to antibiotic and causes. Depending on the duration, it can be acute if it is less than 4 weeks, relapsing if there are more than 3 episodes in 12 months, or chronic if the symptoms persist for more than 4 weeks. Depending on the response to antibiotic, it can be antibiotic responsive, antibiotic dependent, or antibiotic refractory. Depending on the causes, it can be idiopathic or it can be secondary, like depending on the use of NSAIDs, pathogen associated like cytomegalovirus, mechanical or post-operative, there is stenosis, there is an immune associated like primary sclerosing cholangitis, celiac disease or IgG4 or Crohn's disease. We will elaborate further as the discussion will evolve. So, as far as the treatment of acute pouchitis is concerned, so we have 3 RCTs available in the literature. That is by Madden et al. About metronidazole, Shen et al. About ciprofloxacin, and Isaac et al. For rifaximin. In the first trial RCT, that is by Madden et al., they used 1200 mg metronidazole per day, that is 400 mg TID for 7 days, or placebo. So there was a decrease in frequency of stool in 73% of patients in basically metronidazole group versus 9%. In another trial where by Shen et al., they used ciprofloxacin, that will be 500 mg BD, or metronidazole 20 mg per kg per day for 14 days. So again here the ciprofloxacin produced greater response, decrease in the pouch disease activity index, and endoscopic response with less side effects. So this trial favored the treatment with ciprofloxacin. And another trial, the rifaximin versus placebo. So there was no significant difference between rifaximin or placebo in the use of acute pouchitis. So friends, these two basically commensal bacteria are the most common, the frequently found bacteria in the feces, that is lactobacilli and bifidobacteria. So in any patient of pouchitis, there is a significant decrease in the concentration of these bacteria. So we have RCT, double-blind RCT, which compare the placebo versus the probiotic, and in all this trial, they have used this probiotic, that is with the trade name of BSL #3. So unfortunately, it's not available in our country. It is a combination of viable lyophilized 4 strain of lactobacillus, 3 strains of bifidobacteria, and streptococcus salivarius. So basically, the probiotic that BSL-3 was used for prevention of recurrence, and in the BSL-3 patient, 17 out of 20 patients remained in remission after 20 months, while there was no patient in the placebo arm. However, all the patient in the probiotic arm had a relapse after basically within 4 months of discontinuation, and the fecal concentration of lactobacillus and bifidobacteria returned to baseline after 1 month. Having said so means that to maintain the remission, we have to keep this patient on long-term prophylaxis with the probiotic. Metronidazole in the dose of 750 to 1500 milligram per day for 1 to 2 weeks. Basically, it induces remission within 3 days, and the efficacy has been confirmed in a RCT double-blind placebo-controlled crossover trial. Another route can be topical therapy, which avoids the oral side effects, in which we use 80 milligram metronidazole enemas twice daily for 1 week. If the patient is unresponsive to metronidazole, then the cyclic courses of 3 to 4 antibiotic in the combination of ciproflox, amoxicillin, erythromycin, and tetracycline, or another alternative can be budesonide suppository, 1.5 milligram per day. And if there is a frequent lapse, then we have to maintain this patient on long-term low-dose suppressive metronidazole therapy. As I said, if the patient is non-responsive to antibiotic, then the non-antibiotic based therapy can be in the form of oral budesonide, and it has been proved in one of the trial with concurrent primary sclerosing cholangitis with acute or chronic pouchitis, and 33 patients went into remission with oral budesonide. So local enemas with budesonide or metronidazole are equally effective, and this is again has been proved. So if we are choosing enema, then we should go for a metronidazole because of the lesser side effects. Again, the combination of probiotic we have to maintain as a prophylaxis to avoid the recurrence, and high dose of probiotic, like in this study in which they used 2 packets of BSL BD for 28 days, and the clinical remission was achieved in 69% of the patient. This is a one good algorithm for treatment for these patients of acute pouchitis. So we can start with ciprofloxacin 1 gram daily, or metronidazole in the form of 1 to 1.5 gram daily for 2 weeks. If there is a response to the treatment, then the patient is antibiotic responsive, then we can maintain the remission with the help of VSL-3. Or if there is a recurrence, then we have to see that despite the antibiotic there is a recurrence, then this patient is having antibiotic dependent. So then we have to use the combination of probiotic or antibiotic maintenance and antibiotic maintenance. If after the initial course of antibiotic there is no response, then always evaluate for the secondary causes. If one is found, like there is a ischemia or there is a stenosis, pouch stenosis, then treat that cause accordingly. Or if there is none identified, then this patient will end up with chronic pouchitis. Then we have to see for alternative like immunosuppressive therapy or budesonides or biologicals. If patient has a relapse after antibiotic course, like more than 3 lapses in a year, then this is a patient of relapsing acute pouchitis. For these patients, we can use different combination of antibiotics like ciprofloxacin, rifaximin for 2 weeks, or metronidazole plus ciprofloxacin, or ciprofloxacin plus metronidazole, and the response rate is somewhere between 80 to 90%. So friends, just remember that these patients are very tricky, very difficult to manage, and we have to basically juggle between these choices, that is antibiotic, combination of antibiotic probiotics, or combination antibiotic cyclic treatment. Then we can switch over to the steroids or the infliximab. And there is a definite role of basically probiotic and BSL-3 in high dose, that is 3 to 6 gram per day, for maintenance and secondary prophylaxis of antibiotics. Like once we have achieved the basically remission after combination of these antibiotics, then we have to give high dose probiotics, and again there are multiple trials available and which prove the efficacy that if we give these probiotic in higher dose for longer duration, then there is chances of maintaining the remissions are higher as compared to the placebo. With that, we have reached the end of this second part, and the third part, that will be the conclusion. We will discuss about pre-pouch ileitis, irritable pouch syndrome, primary prophylaxis of pouchitis, natural history and prognosis, mistakes, common mistake in pouchitis, and the conclusion. So, friends, I am deliberately keeping these videos short, basically because otherwise it's difficult to maintain the attention of students for longer duration in the present era of shorts and reels. So, coming to the question which I have asked at the beginning of this video, a 30-year-old man with a history of ulcerative colitis and stapled ileal pouch anastomosis is seen in clinic for follow-up. Over the last 10 days, he developed increasing rectal urgency, tenesmus diarrhea. 4 months ago, he had similar symptoms and was diagnosed with acute pouchitis. He was treated with ciprofloxacin and his symptoms resolved with treatment. Which of the following is the most appropriate therapy at this time? So options were metronidazole, ciprofloxacin, BSL-3, mesalamine enemas, or prednisone. So I think now you can answer this question better. So the answer to this question or the treatment for this patient will be answer B, that is a ciprofloxacin 500 mg BD. The explanation for that will be a recurrence of pouchitis after treatment of the first episode is treated with a second course of same therapy that was used for the initial treatment. Metronidazole is another treatment option for acute pouchitis. However, because the patient responded initially to ciprofloxacin, there is no need to switch to metronidazole. In addition, ciprofloxacin is more tolerated than metronidazole, and even in the Cochrane analysis, they proved that ciprofloxacin is better as compared to metronidazole. And the BSL-3 is recommended for prevention of recurrent pouchitis rather than treatment of acute pouchitis. Treatment with prednisolone or mesalamine enema should be tried if symptoms do not respond to antibiotic therapy. So thanks for watching, friends. Stay tuned. We'll upload the third part soon. And if you're watching this video on our YouTube channel, then don't forget to hit the like, subscribe, and the bell icon for all the updates. And it is desired or recommended that for a better learning experience, download the app or join the channel membership, because we are not loading everything as free content. Some of the content is exclusively available on our app and in the members only section on our YouTube channel. So up till next time, stay curious, keep learning, and I'll see you in the next one.